Global South. Okay, and very few. Global South is everyone except those who live in Global North. Now, what is Global North? People in the Western countries, right? Western Europe, United States of America, and some other countries. Only 15% of the people live in Global North. 85% of the people live in the Global South. Global South is usually less developed economically, okay, have less technology in their daily life, but those are the people who actually need the solution. We in India are one of them. Now, why it is important that the solution has to reach the Global South? How much time do I have? We have, thank you. So, if you see here, people in the Global South are underrepresented in the large databases, right? All the large companies of the world, the Google and the Amazon and the Facebook of the world, actually likes to get the data from the large number of people, but the models that they have built is not necessarily, I'm talking about the disease models, not necessarily using the data from the Global South. And the best example is the Human Genome Project 1, and I'll talk to you a little bit about it too, is the data which was actually using the Caucasian population. Now, in addition to that, we have a higher disease burden. What does it mean? All of you in this room, Indians, either know someone 45 or have someone in the family who is diabetic, right? Every single one of them. Wasting our money to the doctors, no, absolutely no benefit. It's only a lifestyle disease. And this is going to go up. Same with coronary heart disease. So we have a higher disease burden. Now you can see, I'm not going to read all these things to you. These are the absolute advantages or what we have today in Global South. But the databases that we use is not from Global South. And therefore, these are the two examples I've given. Everybody knows the example on the right. For the ones that are not from India, this is one of the very famous people's car. Unfortunately, it's not in production anymore. It's called Tata Nano. It was introduced with $1,500, like 1 lakh rupees, but became slowly to 2.5 lakhs. This is the most expensive car in the world, the Rolls Royce, one of the model of the Rolls Royce, which is $30 million. Now, you can see here 200 crores. Now, this is the solution of the global north that gives. Not necessarily a bad solution, but can we afford it? No. Do we need it? No. Do we want it? Yes. But this is what do we want? We want a solution that is affordable, tailor-made for the people of the global south, easily accessible by the people in the global south, and is actually available openly to everyone. So it's very important that we do it. Now that is the reason global south must lead, not follow. Now, one of the example is Human Genome Project 2, and Webin is going to talk a lot about that during the panel discussion. So this is the second version of the Human Genome Project. Some of you are interested can actually just go to the website and find out and why it is going to be important for the next revolution in human genomics. And then finally, one slide about India. What is India, or what can India do to lead this particular process and work with others in the global south? Well, these are the different kinds of data in the healthcare. Okay, this is the information where it comes from. This is the AI tools, the APIs, the frameworks. And to use these AI tools and APIs and framework, we can actually come up with multiple different solutions in healthcare. Why we can do that? This side is actually no-brainer for you, those of you who are from India, that we have a large population, we have a large repertoire of digital public infrastructure, not just the Aadhaar, but all of those. And we have the staff, so we can use all this information for healthcare data to build solution for Global South, not just for India, but also for Global South. But that will require a lot of collaboration and also a lot of talking with other people in the Global South. So therefore, I think the time of India is now. And if any of you who is interested, will be available after the session to talk to you and to discuss with you. Thank you.
I think this mic is not working. Okay, our next speaker is going to be Madhava J, who is a principal engineer at OpenMind Foundation. And he's going to tell us about BioVault, a privacy-first data visitation platform for equitable global collaboration in biomedicine.
Thank you, everyone. Good afternoon. My name is Madhava. I'm a rare disease patient. I'm also a principal engineer at Mind, where I've been working for the last 5 or 6 years on privacy technology. And this talk is on BioVault, but I'm actually from Brisbane, Australia. But a very long time ago, before I was born, my parents lived in India, very close to here. And they loved your beautiful culture and country so much that they gave me this name. And so I wear it with a badge of honor, so thank you. Thank you for inviting me. If there's one thing that I want you to take away from this talk, it's that you can collaborate globally to discover insights without ever losing control of your private data. So Vinay was touching a little bit on the value of data in AI. This is an AI conference. And so the question is, if AI has been trained on all the world's public data, what's the next destination? It's going to be the private data that they don't have. A lot of the conversations at this conference are going to be about what businesses can be integrated into AI and where can the value be found. There's a little bit of a concern that these state-of-the-art models could replace all of these different verticals. But I would urge you to read this blog post, which is a fantastic resource, which talks about one potential defense against this, and that defense is to have a cornered resource. And if you read it,
छिटकने की आवाज आई और बिजली बार है ना तो पहले भी आ रही थी स्पीकर में से आ रही थी लग रहा है हो गया चालू नहीं अंतरराष्ट्रीय लेवल पे बेइज्जती हो रही है
give me a second, I'm on the screen to do it. Testing, testing, testing. Yeah, mic's back. Screen's coming. Sorry, guys.
हमारे क्या दिक्कत है यहाँ पे सब भूख मर रहे हैं ये देखिए सब मर रहे हैं भूख के लिए कोई बोल नहीं रहा क्या उनसे बात करो ना पंकज भैया ना मेन तो अपने क्या कह रहे हो रिप्लाई नहीं दे रहे कुछ नहीं मैंने कॉल किया था उस टाइम उन्होंने कहा था भाई खाने का तो मुश्किल लग रहा है देख लो एडजस्ट कर लो एडजस्ट क्या करेंगे कुछ है नहीं है इसका एडजस्ट कैसे करेंगे हवा से करेंगे एडजस्ट लगता है इनकी सैलरी तो ब्लू एप्पल नहीं है सादा एप्पल है वो क्या चाहिए Sound check karo.
Alright, I think we're good. Are we good? Interview. Hello, everyone. Alright. So, what Lucas talks about in this blog post is that there is a thing called Element 7 hours, which goes into detail about what is potentially defensible in a business environment. And he concludes that private data may be one of the only moats. And such a resource must be truly exclusive, not available for sale at any price, and applied for operation. And so I think in the context of biomedical data, I would say that meets many of those requirements. It's very private, it's very valuable. Health data is probably among the most sensitive and valuable categories of data. So Vinay was asking if anyone here has people in their family with type 2 diabetes. I think a lot of us here probably know somebody who's unwell. I think global rates of chronic illness that are undiagnosed are quite high, up to 10% of the population. And I'm one of those people. So many years ago, I had a chronic illness that I didn't know I had. And it turns out that even a few small letters in your genome can mean the difference between life and death. So my great-grandfather, or my grandfather who had this disease, died at age 40. I'm 41. It's highly likely I would have died last year probably if I hadn't had early intervention. And so I should know about this. But these advances and benefits, they're not really being shared equally. To Vinay's point earlier, I live in a Western country and I can get that diagnosis quite easily now. Yeah, we need to make that more globally equitable. So one of the challenges with data sharing in healthcare is that there are a lot of very important data protection laws, particularly around sovereignty. And these restrict cross-border transfer of human data. But as you can imagine, AI operates best when you add more data, so sharing of biomedical data sets is necessary really to get to that next level of advancement. So the question is, how can we collaborate? And when I say we, it's a collective we, the North, the South, the whole world, while preserving our data sovereignty in each of our countries. To help illustrate this, I have this diagram, and it's basically it's a Pareto frontier, and that's where you have an X and Y axis with two variables that you're trying to optimize for. And in this case, on the left-hand side, on the y-axis, we have utility. And so at maximum utility, we're getting all the value we want. And down the bottom, on the x-axis, we have privacy, which is measured in input epsilon. But what we want there is to have maximum privacy for utility. And at the moment, a lot of what's happening is, by conducting cutting-edge research, we can get max utility, but we have to give up control of all of our data. And so the alternative to say, well, I don't really want to lose my data because of all that value, I don't want to give it up. Importantly, data once copied cannot be uncopied. And so you should consider, what does it mean to share and collaborate with data? But if I was to then keep it to myself, I get zero benefit. And so that's not very good either. And so really what we want to do is we want to try to occupy this space in the middle and actually potentially see if we can get to that top right of the corner and just shoot right off the chart. So let's talk a little bit about some of these traditional data sharing models that people are currently using. So in this diagram, we basically have three different institutions, and you can see illustrated by their different colors. And often what will happen is they will take their data and they will upload it or send it, raw copies of the data, to a data scientist who then brings it all together and does some analysis. One of the problems with this is that once you copy data, you can't uncopy it. And that means that while you might have a legal agreement with that data scientist, this can still lead to data leakage. But the most important thing actually here is not the trust, it's the fact that the original data owners may not benefit from that downstream result. You may not realize this, but often the output, scientific output, the model training, the results are not always shared back to the people who own the data. And so they're being severed from we allow them to access that and kind of do their queries and analysis. Still have to upload all that data, and now you've got to pay for it in a second location. If this is medical data, it's enormous. Okay, some of these data sets are terabytes or petabytes, and you've got to pay for that as well. The other thing is that once you put it in the cloud, you have to protect it. So now you've got another thing where all your valuable data needs to be protected. And more importantly, like Vinay said, this is really only for well-resourced institutions who can afford this. But finally, it does not solve the problem we talked about, which is that data owners don't get visibility into how the analysis is happening. They don't get like the granular control they need to be able to decide on a per query basis or the outputs that are being produced, whether they want to collaborate or participate in that. And it also doesn't really scale to multi-party, which we'll talk about in a minute. So there is an alternative way, a sort of potential third way here, which we, has sort of been coined as data visitation. And the idea in the name there is that we're visiting the data is not visiting us. But it allows collaboration without movement of data. And so on the left, we can see a data scientist or anybody working with data. And importantly, what they're doing is they're sending in code or a question or a prompt. And they have a question whether they want it answered. And on the right-hand side, we have a data owner who we call these data sites. And this is sort of like a website for data. And they retain governance over that data at all times and never share a copy. All they return is the result of the question the data scientist wanted to know. And if you think about it, that's all that really matters. You shouldn't have to have all the data just to have the answer, if that's possible, and it is possible. And so what we've been working on in this project, and as I said earlier, I work at OpenMind, and so you're probably thinking, well, that's one name. So what is BioVault? BioVault is a implementation of these concepts for the biomedical space. And you can see on the right here, we have a diagram of how you can sort of envisage what this is. It's a network, right? of open source, privacy first data visitation for equitable global collaboration. The way it works is we sort of built like an open source peer-to-peer network. The technology and the science and the math behind this has been around for a while. But what we're really focused on is bringing it, the engineering problem of bringing it to the people who need it. So we spent a lot of time on developing things like a desktop utility that's really easy to use, that runs on Windows, for example, which a lot of people don't bother with. It has end-to-end encryption, and it supports arbitrary analysis through a variety of different extensions with technologies like Nextflow and Jupyter. But more importantly, it keeps all your data local, right? We don't ask you to upload data. There's no uploading data facility. You link the data, and you make the data available via an interface, a facade, that allows people to then send in their computations that you can choose to execute against them. And more importantly, unlike a lot of the existing models, we also support federated encrypted computation. And that allows this peer-to-peer network to work in a point-to-point topology to allow more than two parties to basically collaborate together. So we actually, I'll talk about this a little bit more at the end, but we have a preprint that we just launched on bioRxiv a few days ago. There's a lot of work from some people in the panel here and some of the people in the audience. So thank you all. And you can see on the right-hand side, we check out the papers and figures, but some very specific use cases that we wanted to explore that we think are relevant and pertinent to real-world use. And so one of them is the analysis of single-cell RNA set. Now, this is, I'm not a biologist, and so it's beyond me, but very advanced technology related to analyzing cancer cells, looking at advanced genomics. We can also train machine learning models, which is pretty par for the course by now, but it's important we demonstrate that that's possible. And we've done remote inference on very large clinical data sets. And more importantly, there's also the option to do privacy-preserving analysis. And so actually we did some on my own genome. If you see in the bottom right-hand corner there's a little graph showing a little count of some variants that I have that basically is to do with my disease. So that's cool. Finally, I want to talk a little bit about some real-world data and real-world use cases. So it's not enough to basically talk about a theoretical bit of technology and try to kind of tell people that they should use it. We need to actually demonstrate that it works in the real world. And we want to build a product and a sort of experience that is useful by working with real people. And so here are two pilot projects that we just completed before this preprint. We don't have time to go into both of them today, but you will actually hear from Dr. Rana Janani later in her little segment. But I'd like to focus on the first one here, which is with Dr. Karika Weldon. She's the founder and CEO of Genetics, and she's in Bermuda. And basically what happens is she has a Oxford Nanopore machine she uses to do some sequencing. She also collects samples from a variety of participants on different islands in the Caribbean. And that data that gets gathered is stored by her. And in that earlier model that we discussed, there was the idea that traditionally to do outside research, you would have to share that data. And so if Karika wanted to do some of the more cutting edge research, she would need to upload that data to a researcher in America or something. There's a lot of computational requirements, there's expertise, there's a lot of complexity to this. It's not as simple as just having the data. But when we met Dr. Karika, we understood that she had problems with working with these data sets. And so what we did was we built specific workflows that would work against her data so that we could do some very novel and exciting research. And so in this diagram, you can see what we actually did was we had the desktop application running in different islands, and we sent through queries, and we basically were able to analyze the allele frequencies for different populations within the Caribbean, as well as some disease classifications. So there's a particularly pernicious disease that called APOL1, which creates like a chronic kidney disease, and they have a very high prevalence in the Caribbean. And using our technology, we were able to sort of provide remote analysis in code so that Dr. Karika could verify results that she already had and confirm new results without having to share that data with us. So we were actually able to take those allele frequencies and do something fairly cutting edge. So I believe this is a bit of a world first in a few ways. And what we did was some of this data has never been analyzed before because of the sensitivity of it. But we compared it to a thing called Nomad, which is a global
sort of ancestry and variant database that shows breakdowns of different ethnicity groups. And we're able to compare how it compares to those. And you can see those plot charts at the bottom. Yeah, we all did that all without uploading any data. So we think it's a bit of a world first. Anyway, so look, bioRxiv has our preprint. There's a QR code there if you want to scan that. Come talk to us later if you want to hear more. We'd love to partner with some new people, but also if you're interested in just getting involved in like open source or contributing or have questions about policy or anything, we have people here to talk to you about it. So thank you again for listening, and yeah, enjoy the conference.
And actually, Dr. Rana was initially going to be here today, but unfortunately, she had a family emergency, so she actually recorded a video for us that I'm going to play.
Peace upon you all. My name is Rana Dajani. I'm a professor of molecular biology from the Hashemite University in Jordan. Unfortunately, I wasn't able to join you today in India at the AI Summit because my mother passed away recently. And this was a reminder of how our research and science cannot be isolated from our humanity and serving humanity. Ultimately, as scientists, our goal is to serve humanity. I'm a molecular biologist and I work on genetics of ethnic populations in Jordan, the Circassians and the Chechens, trying to uncover novel gene risk factors for complex diseases such as diabetes. I'm also an expert on the epigenetics of trauma in vulnerable communities such as refugees, Syrian refugees, Palestinian refugees as a result of the atrocities committed by oppressive regimes and powers around the world. Therefore, I generate many databases that enrich biomedical research globally. Now, biomedical databases and datasets usually represent or should represent diverse populations, and that diversity is essential for advancing precision medicine and for ensuring that AI systems in health are accurate, fair, and globally relevant. This is especially important for the Global South, where populations remain underrepresented in biomedical research and AI development. Without equitable data sharing, health innovations risk reinforcing global disparities rather than reducing them. And that's the reason we're all here today, to try to reduce that. Yet much of this data remains siloed due to registry, regulatory, sovereignty, and privacy constraints. Existing data sharing models all require complex infrastructure, specialized expertise, and significant financial investments, which, as a country from Jordan, we do not have. These barriers, therefore, disproportionately impact institutions in resource-constrained settings, limiting our ability to participate fully in global collaborations. That is why I was so excited to join the BioVault team. BioVault provides a practical domain-agnostic framework for privacy-preserving biomedical collaboration, supporting AI development and genomic research while advancing equity, sovereignty, and global participation in health innovation. We worked with the creators of BioVault and tested my data sets for the Circassians and the Chechens, and were able to reproduce authentically the results. So this is very promising, and I hope you will learn more as this panel unfolds. I look forward to such approaches becoming the norm in the future. Enjoy the conference and the rest of your day, and hopefully we will collaborate in the future to make this do better science to serve humanity. Thank you, and goodbye.
Okay, next we actually have Andrew Sultan, who is from University of Oxford, and he's going to tell us about fair, scalable, and private AI using routinely collected hospital data.
Thank you, Dawn, and thank you all for coming to our session today. One of my aims today is to talk through a scenario that we faced during the COVID-19 pandemic at Oxford University Hospitals, which is one of the constituent hospitals within the NHS, and talk through a machine learning approach we took to try and solve that problem using data that was already routinely available to us. I'll then talk a little bit about an extension into how privacy-preserving techniques, in our case federated learning enabled us to achieve our objectives and talk about one of the strategies we use for deploying that technology, for making it available across the NHS, and therefore the relevance that that could have to other settings, including, for example, countries like India and elsewhere, and I'd be delighted to have conversations afterwards and take that forwards. So to set the scene of one of the core challenges in clinical artificial intelligence, it's that data is fundamentally siloed. It exists within individual hospitals, and those hospitals are separate legal entities, and because of regulation within the European Union and the United Kingdom, that data can't be shared freely without, for example, the appropriate approvals, the appropriate ethical considerations, and a full understanding of the risk that is involved in that. And so the traditional process is to seek those approvals, to relocate that data within either a university or a company or the organization doing the development, to then clean that data, and you're already one step removed from the people who understand the nuance and the artifact in that data, to develop models, to validate them, and then to move towards deployment. And I'll start briefly with a case study, which is the work we did at the beginning of the COVID-19 pandemic to build a model that can be used to rule out COVID-19 in emergency departments. Now, the big challenge, of course, was access to testing, and even within a relatively high resource setting like the United Kingdom, at the start of the pandemic, it would take 3 days to get the result of the COVID PCR test. Now, that came down to 2 days, and then 1 day, and then 12 hours as on-site testing came on board. But there were still significant challenges in being able to run a hospital operationally, i.e. have patients flow through the hospital with a 12-hour time lag to know if they had COVID-19 or not. And unfortunately, that was implicated in the spread of the virus amongst vulnerable patients. And to talk through the workflow at the front door, what happens within the first hour is every patient who comes in has a set of routine data that is pretty much standard across middle-income countries and higher-income countries, made up of your vital signs, your blood pressure, your heart rate, your temperature, so things that are very easy to measure, done very quickly, done very routinely. And also panels of blood tests that are routine and are standard of care across the developing as well as the developed world. So this is the real basics of blood testing. So performed for almost every patient being admitted within 1 hour. Now, patients afterwards are then transferred to the ward, but the selection of ward was guided by the result of their PCR tests, and this is the challenge that we set out to face. And the clinical challenge is that a test that rules out COVID-19 within minutes is what is needed. That's what's demanded in the hospital to make sure that you have patients who have COVID away from patients who don't. And so we set out to build the Curial screening test for COVID-19, which is essentially working with that tabular data that can be represented in a table. And we went on to validate the model that we built across 4 NHS sites. So this would be Birmingham, Bedford, Portsmouth, and then for the second COVID-19 wave in Oxford across 72,000 patients. And we showed that that model could perform quite well. And we were fortunate enough to then go on and pilot our test. We deployed it at the emergency department of the John Radcliffe Hospital, and for a study of 520 patients, showed that you can have a result within 45 minutes of a patient arriving in hospital. And we showed that we got those results faster than lateral flow tests and faster than PCR tests by some hours, actually, by considerably. And so I guess the question here is, what does this have to do with data security? And this is it gets to the core of one of the challenges of this work. Now, a big challenge of working with data from multiple NHS sites is that although every site was aligned in its incentives, every site wanted to see a solution for COVID testing, we had significant challenges getting access to data, even within the NHS, even where people's incentives aligned, and even in the pandemic situation. And so we asked the question, how can we deal with that data distribution problem? How can we deal with that core challenge that slows down medical research for understandable reasons and approach that with a nice technological solution? And of course, there have been several leaks in the past, several instances where data has not been handled properly, and so there is understandably concern around it. And the technology of federated learning proposes to take out that data transfer step. So instead of you moving data from hospitals to your secure environment, you perform training by bringing the model to the data and not the other way around. And so in doing so, you're sending the parameters or the weights within a model, which are essentially mathematical numbers that you can't readily infer patient data from. And you can do that in a way that's secure and encrypted. And there are various technologies around it to improve that. And so we wanted a platform that in the early days of federated learning, where no one had heard of it, we needed a platform that anybody could use. We needed it to be user-friendly. We needed it to be so that people who didn't have a background in federated learning could just get this platform up and running. And we used this device called the Raspberry Pi, which is a cheap, small computer. It's the size of your credit card, just a little bit thicker. And it's sold for about £40 in Britain, so it's about 5,000 rupees. 5,000 rupees or thereabouts. So it's relatively inexpensive in the world of healthcare technology. It's a relatively cheap device. And what's nice about these devices is they can run Linux. You can run a full operating system on it with a full user interface. And so we were able to put all of the software you need to take part in this study to develop a COVID-19 screening test onto these devices, and we were able to install Ubuntu onto them, give them a nice user interface that talked you through everything you had to do. So a hospital needed only plug it into power, plug it into a monitor, plug in a keyboard and a mouse, and off you go. You follow the instructions on screen and take it from there. And of course, we had all the governance approvals around it. What's particularly nice about this device is it uses a removable micro SD card. And these cards are very, very cheap. They're about £4 to £5 at their cheapest in Britain, so that's around 600 rupees or so. And so the cards at the end of that work can be taken out and destroyed securely in the same way as hard drives are destroyed at the end of life. So you can be certain the data within the hospital has been safely fully controlled. And we were able to show that if we were to do that, so to send out devices to 4 hospitals and perform the training on these devices while they're physically within the hospitals, that we can produce a model that performs far better than if we didn't do that, and produce a model that was less biased, that had more consistency in its performance as it had seen a greater range of data. And we were very pleased with the results of that, and particularly that we were able to show that we could use this technology to deploy a test on data from Bedford hospitals, and it performed just as well as it did for data from hospitals who didn't participate. And we see this approach as a way that hospitals in areas that, for example, do not have access to the resources that we might in the UK to take part, with a relatively low budget, they can join a federation like this, join a study like this, contribute to model training and model weights. And the value add of this is making it as easy as possible to use it. And we were very fortunate to have significant coverage at the time. And so I suppose a thank you to my collaborators for this work, David Clifton over in Oxford, David Eyre in Oxford, and in the emergency department, Alex Novak. And that's it from me.
Thank you, Andrew, for that wonderful talk. And our last speaker is going to be Francis Crawley, who is going to talk about piloting global AI policy and data visitation for quality in healthcare data.
Good. Thank you, Dawn. So essentially what we've been looking at with our distinguished panelists here today, under the leadership of Wei Din, he's being quiet. And, but what we're really looking at is a new technology and how we can do something better with data and interrogate that better for the purposes of health. And we've seen the slogans here for the conference here: welfare for all and happiness for all. That's wonderful. That's a hard road ahead. And certainly one of the things that we'll have to achieve on that road ahead is health for all as well, the WHO slogan. So that's really what we're concerned with here. I think the entire AI summit here is really about the society we're moving into. So it's not for some small reason that the President, Prime Minister Modi is coming to open up your session here, and that the whole of the Congress and the whole of the governments in the states as well are behind us here too. It's very important for the future of India, but also for the future of the world. So it's an important thing that we have here too. And what I wanted to say is, with these technologies, it's not just a technology, and that's what the entire conference is reminding us. It's not just a technology. It has to do really with the whole of society. So when we talk about this data visitation, we're bringing in new technology to interrogate the data. The data is the basis of our science, but it's also the basis of the information that we exchange for all the other things in our lives as well. So this data is important to us. It has personal value, it has societal value to us as well. So when we work on these technologies, we have to ensure now that we develop within the technologies the kinds of considerations that would lead to, let's say, welfare for all, happiness for all, or health for all, things like this. So just a few thoughts for myself. I don't think the slides matter too much here. But so data visitation is a method. And as we know in science, method is the key. It's not new. Method is what allows you to develop new knowledge. So when you develop a new method, and that's what we're presenting here, a really cutting edge method as well, so congratulations for that. But with that method, we're able to interrogate data better and receive more information from it. And this is important here too. But health-related research is bounded by and determined by far more than simply method, even far more than simply science. It's impregnated with society. So we have rules for it. We have rules about how you have to do it. And those rules are not accidental, and they're not just there because it's like tax rules or something. They're really there because they want to protect people, protect the integrity of the people, protect what people think is important to them. And we know genetics is important to people because it tells a story about us that we believe is a really important story, right? So what we want to do with this technology is not only make it possible, let's say, to do the scientific part of it, but also to ensure that within that scientific part, we have the considerations that we need to have for society. So we have to have things in that have to do with not only the science, but also we're really concerned in a certain sense with reliability, with acceptability, and I would say most important, with veracity as well. In other words, our science has to be reliable. So the conclusions that these fantastic scientists are drawing from this data visitation models, we have to be able to know that those conclusions are ones that we can work with, that they actually give a picture of myself as a patient or ourselves in society. We have to know that that's correct. And we also have to know that the work that these folks are doing is acceptable, right? It has to be something that society will accept. India is very sensitive about that too. You have very strong ethics regulations in place and so forth. The ICMR and so forth, as you know, is a very strong organization, and they really protect the idea of what's important for the populations within India. And that's the way it should be as well. So we need to think about that too. So thus we need to be able to, and going forward, we can't have ethics just in paper. We can't have ethics in PDFs. We can't have ethics just in committees. It can't be just an informed consent form. Going forward with AI, especially with AI, we have to put the ethics inside the techne, inside the technology. It has to be built in. That's going to be hard to do, but we have to do it because we can't do it the way we've been doing it. AI just goes too fast. So we have to make sure that the machines that we're building and the computational power that we're using within those machines also are done with not only within, let's say, scientific parameters, but also within parameters that are acceptable to people in the society where we live. So I think that's important here for us here too. So this is propaganda. You don't have to, you can ignore it, but it is a propaganda. But we did some publications on this within our European Open Science Club and Research Data Alliance working group to look at, okay, what kinds of considerations should an ethics committee take when they're looking at health-related research that involves AI? That's one thing we looked at. And then we also looked at what kinds of informed consent should we be thinking about going forward for patients when they're making their data available for the kind of research that they're doing here. So we just tried to think about that, and we wrote this propaganda there. We also looked at then some also quality issues as well. So that seemed to be important to us too. So, and I think this is the wonderful thing about data visitation, because I think what we can do, you've heard this already, so I don't have to repeat it. But I think what we can do with data visitation is not just analysis. We can do the analysis, but we can do much more than analysis with it. We can do quality control. And this is really important because we have to know what the value of that data is. In other words, we have to know the real world value, if you want, of that data. Because AI, however wonderful it is, the way it is today anyway, it has no access to the world. So if it doesn't have access to the world, it has no access to truth, right? It has no access to know that that data actually represents this person here. We don't know that that data actually represents you. We think it does, but we want to make sure it represents you or represents your genome or whatever it is carefully. So we need to be able to not only use this methodology to analyze the data, to query the data with regard to, let's say, certain questions that we have, but we also can use it to do quality control. And we did some of that with another organization before. I won't talk about that too much, but I think that's what we can do. So our objective really, one of the objectives we have, not just to do the scientific analysis, but also to put this in place. So we've come up with, and we're just developing this, it's not yet propaganda, but we'll try to put it in propaganda. But we have these efficient principles that we're working out. But more importantly, and this gives us a kind of ethical background for what we're doing, but we're also working on these pilot principles. And what we want to do with the pilot principles is more or less like, you have the FAIR principles for data, you have the CARE principles for data, and you have the trust principles for data repositories. Well, we want to have principles like this for artificial intelligence. And that's what we're trying to do with both the envisaged principles and the pilot principles. And that is to impregnate those with purpose, integrity, law, openness, whatever that means, and test it. That's what we thought there first here. So we want to move really from instruments, from pure instrumentation in a certain sense, to working purposely. But that means working purposely within society. Or, if you like, from moving from technology to people and their health. That's what Laban is actually trying to lead us on in that path here. And with that, I'll just stop with what I think is one of the most important remarks, and for me anyway, in life, is that morality is the basis of things, you could say all things in fact, and truth is the substance of all morality. One thing that ethics and science have in common, and it's really important, it is veracity, it is truth. And we have to bring those things together within our AI technologies. Thank you very much.
Yeah, thank you so much, Francis. And now we have a little bit of time for some panel discussion. I'm just going to put this up on the slide. Yeah, so I guess we don't really have a ton of time, so perhaps we'll just start off with one question, which is, you know, like, we have a lot of really amazing technologies that these panelists have already showed today. And what do you think are some of the challenges of translating some of those technologies to real-world implementations? And also, how can some of the people in this room who are sitting here help with that? Does anyone want to go ahead?
I think at this stage people probably realize that we're living in the post-AI world. Technology is amazing. And so I think we're in a sort of engineering bottlenecked world. So bringing this technology to where it needs to go requires boots on the ground, you know, sort of FDE, getting people there who have the expertise and capacity to integrate it with the people who have the problems themselves. So technologists like me are not domain experts in problems, but we can help bring the technology to the problem.
Okay, yeah. I think one of the most important things that we should all think about, especially when it's related to human health, is we have to start from where it impacts everyone in human terms. And that's not just about technology or about policy, but principles. You know, and all those are important, but ultimately we have to start from, you know, how does it affect each and every one of you? How does it affect your families and your health? And technology is a critical enabler, but when you work backwards from there, you can also see all the additional support layers that must be in place to make it implemented responsibly and sensitively, including principles, including policy. So I think if we work backwards from the bigger goal of disruption, of making everyone's lives better, I think that would show us a path on how to implement it.
What was the question again, Don? I look at it slightly differently. We talked about data visitation. I'll just switch into Hindi. आपको समझ में आया है data visitation क्या है? समझ में आया ना? कोड और एल्गोरिथम डेटा के पास आएगा, डेटा नहीं जाएगा वहां, ठीक है ना? तो डेटा की सॉवरेंटी जो है वो बजाय रहेगा. तो अभी आपको एक सवाल मैं ये पूछता हूँ कि दैट इज व्हाट शी वाज आस्किंग, व्हाट शुड वी डू, व्हाट शुड वी वर्क ऑन. I think that's not the right question. The right question is that what should you do is what you are passionate about. I don't care about what's the problem is. The problem is we try to work on something that we are not good at and we are not passionate at. Then we ultimately fail. So all of you in this room, if you are passionate about data, you will be good at it, no matter what you do. So the important thing for you, young audience, particularly students here, is there's a lot of things to do with data. Data is floating around. Then why are we not using data? Because either we don't know how to do it, or we are bad at it, or we just don't enjoy doing it. So I think if you enjoy working with data, find a problem, and also at the end of the day, all this problem must lead to a solution and make some value. The value for person one could be money, value for person two could be something else. So there must be a value attached to it. Without value, you will never work on that. So find out what you're good at, what you're passionate about. There's a lot of data, the experts sitting there, go and talk to them, find what you can do with the data to get a solution. And in fact, we are talking about healthcare. The other thing we were during the break talking about, India and the global south has a huge problem on agriculture. Water, clean drinking water, agriculture. Agriculture is one huge area with just waiting to be infused with data-driven solutions. What should farmer do? What type of seeds should the farmer sow? What is the right season to sow the seeds? What is the right season to actually harvest the crops? These are all data-driven solutions. These are local solutions. One solution which is in eastern UP may not be the right thing for Kerala. One which is good for Gujarat might not be good for Nagaland. So what you need to do is get the data, be passionate if you are, and the solutions will be there. So that's what I would say, just to turn things around.
I really like Vinay's answer. Now, I think if I reflect on examples of projects that have been successful, not just within the United Kingdom, but wider in Europe and around the world, what they all have in common is that there will always be a champion at the heart of it. There'll be one individual or two individuals who had a vision and had the passion and the nous to pursue that vision. And that's why I think passion is so important in seeing it through. Now, I think there is a second aspect, which is in around, many of these technologies are well understood by people in this room, well understood by technologists, well understood by people who are young and passionate about what they do. Institutions that have been around a long time, to them these technologies might be new, to them these technologies might conflict with existing organizational policy or with existing organizational direction of travel. And a huge role for people to play is in saying, I see an opportunity for this technology to really help with a problem, and almost going out and selling that technology, not for money, but selling it in terms of the benefits it can bring, how it can align with what others want to do. And then there's the execution work. Now, I think being a professional plus a data scientist, I think is an excellent place to be. I think being an engineer as well as a lawyer or a doctor or an accountant, or pick your profession, pick your field. I think that's really important. It allows you to bring that deep domain expertise with the technology skills, and that's recognizing the two are inseparable.
Yeah, so I think all great answers. Who here has used ChatGPT? Yeah. Does it feel magical? Does it feel magical? I'm telling you, it feels magical. I think we need to realize we're in this post-AI world now. We should no longer be restricted by what we used to think was possible. We should now be thinking about what we want as a society, right? As a group of people, what do we dream of? Do we dream of having all of our family members be healthy? Do we want to cure all that disease? Let's do it. I mean, why are we waiting? Like, if we're restricted by the capacity and capability to implement things, that's no longer the restriction it used to be. So I'm very passionate about this, as you know from what I said, and I think we should have action to get things done, right? We should take action, get those principles and those moral values that we can unite on, and then get together and just do it with the passion that we have to do it.
I think actually we're running out of time for more questions, so please come up and talk to these very enthusiastic and passionate panelists afterwards. And actually, to end off the panel and our session, we're actually going to have Wei Bin to give us some concluding remarks.
Thank you.
Presentation.
So in 2003, even though most of you aren't in the biology and genomics field, but probably all of you have heard of the Human Genome Project, which brought humanity into the age of genomics, into the genomic era. And why was that important? Because the genome, as Vinay had given everyone explanation of, is it's a blueprint for who we are. But all of us are very different. Even among Indians, there's huge variation. So much variation that is unknown. So if the original intent of the Human Genome Project was that it's a public good, that it's something that everyone in the world can benefit from, then how can that be true if there's still so much gap in access, in representation, in useful knowledge, in implementation at the national level? What they did get right in the Human Genome Project was that they ensured it was a public good so that researchers could take this initial draft in an open way and openly work together to explore how to take that forward. This was 23 years ago, 2003. But now in 2026, there's been so much progress. There's been incredible leaps in the technology development. There's been incredible breakthroughs in data generation and the science. There's been incredible exploration into precision medicine and how to use it in things like cancer treatment and in a lot of other things. But even though it's very impressive how the field of genomics and biology has developed in the last 20 years, but if you look at it in human terms, we have to go back to human terms. If it's a public good, it's not a public good just for researchers. It's not a public good for people to write papers or for companies to just make a bunch of money. For it to be truly a public good, it has to be able to touch each and every one of you and your families and your children. It has to be something that, because of it, one day we can all say we truly live longer and healthier because we fulfilled the promise of the human genome as a public good for everyone. So, the only way that this is going to happen is that we have to come together in a much bigger way, and we have to do something much bolder. We have to do something where we remember the human impact as our measurement of success. And this is precisely the reason why a group of collaborators and scientists and leaders from 14 countries came together to write that editorial to ask for a Human Genome Project 2. Because the goal of the Human Genome Project 2 is not just science. It's global precision health, precision public health. Its success is only measured by whether it really enabled whole populations around the world to live longer and healthier, to enable countries to become more sustainable and prosperous. And guess what? If it's something for humans, for humanity, who's most of humanity? What did Vinay say in his talk? The Global South represents the vast majority of humanity, yet we have a big imbalance in terms of our participation, our access, and our ability to benefit in it. But this is a challenge that no one country can solve alone, which is why the scale of this project requires everyone to come together and to do it. So this is something for all of you. Think of it as, it doesn't matter if you're from genomics or not. This is something that one day wants to benefit you, your families, your children, your loved ones. And this is such a multi-stakeholder effort that it's not just about the scientists, it's not just about the companies trying to lower costs and make things available. We need to invent the future. This is why we need to build it. So, what you saw here today with panelists here and what they shared is an example of an attempt to solve some of those realistic problems. Because there are certain problems that are red lines that we can't cross. We have to protect sensitive data. We have to respect sovereignty and privacy. We cannot open that to risk. But there are innovative ways, as you have seen today, where you could actually use technology and innovation to preserve privacy, but at the same time still enable open science and benefit sharing. And so, to conclude, to all the software engineers and to all the entrepreneurs and software developers, please be inspired by this and use these initial efforts to try to come together and build the future and solve the problems. We need your expertise. And also to all the clinicians and scientists, please find ways to support the software engineers, to do cross-domain collaboration. And finally, to the policy makers, please find innovative ways to support this and future-proof the implementation. Thank you very much.
Thank you so much. And so to conclude, we hope you're inspired, and also at the same time, we have a tech meetup tomorrow. It's at the India International Center if you want to come over. Yeah, so thank you so much for listening, and thank you so much for yeah.
Do come to the meetup. Hi everyone, I'm Dave. I work with Madhav at OpenMind, and it's been a pleasure talking to all you guys. We also have a few people at the back. Show your hands, put your hands up. Feel free to come and talk to us. I've taken the mic because there is a memento for all of the speakers. So I will let you one by one. We'll start at the end. Francis Crawley. And next we have Andrew Salter. And thirdly, Vinay Panda. Wyden Lee. And Madhav J. And last but not least, our moderator, Dawn Chen.